Thank you very much for inviting me to speak to you for a little bit. I'm going to be reasonably brief and just try to set some context from the NHS's perspective before we get into the good paper that you've written. And I'm going to try to shy away from talking about the money or what's going to happen tomorrow, except for this first little bit. I mean, we're all kind of waiting to see what happens tomorrow, and the omens are being checked as we speak, I'm sure. But I mean, it goes without saying that we obviously clearly think that the NHS is structurally underfunded. It's something that Simon Stevens made the case about just a couple of weeks ago, and he's endorsed some work done by the King's Funds, the Nuffield and the Health Foundation that says we also need something closer to the kind of in the zone of the 4 billion mark. So it's clearly the case that we feel that the NHS requires further funding. It's also the case that we recognize that social care is structurally underfunded, and we've been making that case as loudly as we can be in front of parliamentarians publicly and other places. But you know, it's important, I think, just to put it out there that we don't think that either of those services are well funded enough, and they clearly have cross impacts on each other. We can't go on pretending that just sort of sticking them together when they're both underfunded is going to get us to where we need to be. That isn't the case. So we're clearly in a kind of time of real constraints. But I want to just sort of set that aside, because we can debate it all we like, and the world will change tomorrow or possibly not. But I want to talk a little bit about what we're going to try to do, whatever the money situation kind of looks like. If I can get this to work. So I'm going to make kind of 5 observations or predictions, probably foolishly, about what the direction of travel for the NHS will be in the next few years. And the first one is to observe that we're going to be in the business of developing systems. And that sounds like a simple and a kind of obvious thing to do, but actually we've been developing organizations for quite a long time, and principally acute hospitals. Perhaps belatedly, you might say, come to the realization that there are systemic problems out there. So whether it's accident and emergency and the pressures on hospitals, those are not things that fall just to hospitals. They're, that's down to social care, that's down to primary care, that's down to 111 services, that's down to all sorts of other influences. So we've got to tackle those sorts of issues in a systemic way. That's also clear of some of our big kind of client groups or patient groups, like older people. If we're going to give older people the sort of service they need, then we've got to get organizations working together in a systemic way, joining up services. And so we're going to be developing in a kind of conscious way systems over the next few years. And this is going at different speeds. So some places are already doing pretty well on this. And we're actually, this part of Buckinghamshire is not a bad example of that. Places that are roaring ahead, and others are a long way behind. So we're going to accept that there are different speeds, but we're going to have to get everybody kind of on that road of travel. Secondly, and this is just to, so I think what we're going to see in the NHS anyways is the realization that we've got to simplify the landscape a little bit. There's too much fragmentation of organizations, or too many organizations perhaps. And while I don't want to kind of go the full hog and say, you know, there's going to be mergers all over the place or that we'll adopt local government boundaries, I do think that where other things are being equal, that will be appealing to try to get to fewer organizations, fewer structural complexities, and I think that's something that the NHS should really be thinking about. So where, for instance, there is a county council that overlaps with a kind of coherent community, we want to be trying to bring together commissioning on that same footprint. That won't be the case everywhere, but in some places that is clearly going to be part of what the answer is, to build systems, to declutter a little bit. Thirdly, and we've been slow off the mark on this, so this is definitely a bit of a mea culpa, but it is very clear now that the kind of best systems really are distinguished by local government leadership, and that we've got a number of our kind of leading systems like Greater Manchester, like Nottingham, like Bedford, Luton, Milton Keynes, like Buckinghamshire here, like Suffolk, where Colin's from, in ways where local government has been a big part of this, and maybe it's been harder fought than it should have been, but building health systems, sustainability and transformation partnerships are laterally coming to the view that we've got to do this alongside of local governments, and so we're trying to be much clearer with our constituency that has got to be part of what we do. Building strong relationships, getting local government involved in decision making is going to be part of making systems work and making them deliver for residents and patients. But we're not doing just systems for system's sake. So it's not just kind of like slide decks and governance and all that sort of thing. And there are perhaps too many parts of the country that are still caught in that phase. For me, systems are there to help integrate services, to join them up between GPs and hospitals, between mental health and physical health, but also between social care and the NHS. And we've got to get going on this integration journey. We are in many places. I think, again, in sort of different speeds. And I think kind of whatever becomes the green paper, there's going to be a need to do more of that. One of the things you see about accountable care in other parts of the world is they are driven not because of top-down exhortations or directives. They are driven because they need to moderate demand, because they need to control the utilization, they need to get better at controlling the costs of their service. They're driven to get into the business of what we would call social care or services for elderly people. That's true in the US, that's true in Germany, it's true in lots of parts of the world. So I think we will find here, for their own logic, for the logic of trying to get upstream, we will get much more integrated at different speeds, not everywhere the same. And I think, you know, in the absence of more national, you know, a stronger directive from the government, that's to be applauded. Perhaps bottom up is the best way to do this. And then finally, I just want to make the point that joining up services is all well and good, and that is part of the step. But what we're trying to do then is get to the next level where we're doing what we would call population health. I think what many of you would call tackling the wider determinants of health. So it's clear to us that we've got to begin to get better at getting upstream, moderating demands, understanding how we can take strain off of hospitals, how we can do more in integrated primary care, how we can tackle housing alongside our partners. These systems ought to be vehicles for doing that sort of thing. They aren't everywhere, I understand that, but in the best places they very certainly are, and we're coming to the realization that we've got to analyze and segment our populations, change the kind of one-size-fits-none model that we can have in lots of parts of the NHS, and instead tailor it to those people who are most at risk of ending up in hospital or having an acute deterioration of their health. So those are a few kind of observations about where I think we're going. Systems, integrated systems with local government at the heart, and trying to get ahead of population health and upstream. So I'll leave it there, Colin, and see what Richard's got to say.
Richard. There you go. Right.
Thank you, Colin, and good morning, everyone. Thank you for inviting me to your conference. I have some good news and I have some bad news. The good news is I'm not using slides, and the other good news is that we are going to get a green paper. The bad news is that there is no more good news. But I hope I won't depress you too much. It wasn't that long ago during the election campaign where the Prime Minister described a vision for the kind of country that she wanted Britain to be, and that included, I quote, the first ever proper plan to pay for and provide social care. And the manifesto went on to declare, where others have failed to lead, we will act. I suppose we could add a postscript to that, but not just yet. But in fairness to Theresa May, this is now the fifth government that has made big pledges about sorting out social care, going back to Tony Blair in 1997. And I will return to that point later. So I want to talk about what I think we ought to look for in the Green Paper. I want to set out 6 tests that we should apply. Take stock, now we have the announcement last week and what that means. And then finally, I'd like to offer you some takeaway points for local government generally and for county councils specifically. So what are the 6 tests? I think the first one is that the Green Paper ought to set out a proper long-term plan or a framework to tackle some of the fundamental challenges that we have in our social care system, which are not just about money. The NHS, for all of the faults of the 5-year forward view, it has a plan, it has a sense of direction. Whereas the adult social care system in England currently is rudderless. There is no plan, there is no framework, there is no strategy. And And again, in fairness, successive governments have not really risen to this challenge. It wasn't properly addressed in 1948 because social care wasn't really an issue then. You know, we spent the last 69 years muddling through. We're still operating a means testing system that is based on the 1948 National Assistance Act. We are still largely providing very traditional services which generally have been untroubled by the kind of innovation that has transformed many other aspects of our lives and other services that we use. We know that the interface with other key services such as the NHS, the benefit system and housing doesn't work that well in many places despite everyone's efforts. And we have the most appalling workforce problems. Some of our metrics in the adult social care workforce around recruitment, retention, skill levels, pay levels are the worst in the economy. And if there was an international award for the most complex, obscure and unintelligible way of funding a major public service, social care would win it hands down. So I count at least six, I think possibly 7 separate funding streams, including the hidden subsidy from self-funders, which you have highlighted in some of your work through the County Council network. And not least, the public generally remain absolutely clueless about their personal responsibility for care costs. As the election campaign illustrated very graphically when the proposal to raise the means test threshold to £100,000 was greeted with horror, oblivious to the fact that that would actually represent a 4-fold improvement on the current system. So we have some deep-seated challenges here which are about sustainable funding, reform of delivery, workforce strategy and planning, and public awareness and engagement. And the Green Paper really needs to sketch out a framework to address that over the long term. The second test is that despite the debacle about the election pledges, it does need to face head-on the funding challenges and the key question of where does the money come from. No shortages of very well-researched and evidence options and ideas, both in the UK and abroad. And if we look abroad, we see actually that most countries use a mixture of methods with varying degrees of public and private funding. And in some ways, the choices are as much about values as they are about technically superior options. I think we have reached now the end of what short-term sticking plasters like Better Care Fund and the Precept can achieve. And we need an open and transparent grown-up debate about where the money should come from and the consequences of doing nothing or doing very little. So absolutely essential. Green Paper tackles that head on. The third one, the third test is one we're already in difficulty with, and that is that the reform of social care needs to address the needs of working age people as well as older people, because working age people are about 1/3 of numbers of people using long-term care and represent, I think, almost a half now of local authority adult social care spend. So it has to be a social care system that works for everyone, to coin a phrase. And of course, the Green Paper announcement has said that the focus will be on older people, and there will be a parallel work stream looking at the issues for working age people. I suspect that decision is a political one rather than a policy one. I think we perhaps should reserve judgment until we've seen more detail around this work stream for working age people. But we need to come back to this because you will be aware that one of the biggest budget pressures now on local authorities in social care is from people with learning disabilities and other complex needs who are not necessarily older people. So we will have to come back to that and hold the government's feet to the fire, I think, on that really important pressure. The fourth test is about how you get the balance right between spending money on protecting people from catastrophic costs, as opposed to adequately funding the public system for people that don't have houses or savings or whatever. And the coalition government, in fairness, I think made a lot of progress through the Dilnot Commission. It passed legislation, it committed, I think, over £5 billion to implementing a cap and a reformed means test. The mistake, I think, was not to attend to the needs of the publicly funded system. And when those pressures began to mount, then all of the Dilnot stuff was postponed, and that £5 billion was lost. So getting the balance right, I think, is really important. Funding reform that is only about caps and floors and means test thresholds will not work. The fifth test, I think, is about the importance of a staged approach to reform, especially funding, because this is not going to happen overnight. And when we were doing the work with the Barker Commission at the King's Fund, I mean, the conclusion of that was that actually if you take a long-term approach, as other countries have done, and providing you face up to some of the hard choices about where the money comes from, it is possible for us to devote a bigger share of our gross domestic product to health and social care. And indeed, if you look at the OBR projections for long-term public spending, the really kind of eye-wateringly big figures are about healthcare and pensions. Social care, the numbers are much more modest. So actually, if you take a phased long-term approach, this issue is fixable if you take a long-term approach. And it's a big challenge, I think, there for the social care sector, that we have to be realistic about what we ask for in reform. We are not going to get from the current system with all its faults and problems to the system of our dreams in one standing start. It's going to take years. And that's my final test, really, which is because it's going to take a long time, it needs a cross-party approach. And we need to learn the lessons of this. In the 2010 election, Labour got hammered about its so-called death tax proposals. And in this year's election, the Conservatives got hammered about its so-called dementia tax proposals. And the minute these political slogans appear, it makes it impossible to have a sensible debate. And as long as social care funding is politically weaponised in that kind of way, particularly around election time, we are not going to make progress. And again, we need to reflect on the fact now this is the fifth government that has tried to do this. So I'm not convinced that we need another commission as such, but we do need a cross-party approach, and I thoroughly applaud the initiative of 90 MPs who recently wrote to the Prime Minister asking for some sort of cross-party convention. And actually, I suspect across the parties there is a broad consensus about some of the principles that we should apply. So we've got the announcement, and I mean, it's good in a way that there is still going to be a green paper. There was doubt about whether it would appear at all. But it's disappointing that the timescale is delayed. I mean, this will add another 2 years. On our website, we have a timeline of social care funding reform initiatives going back to 1997. If the Green Paper doesn't appear till summer, and the Department of Health does tend to take a very flexible view of the seasons, then there'll be a consultation. So we're unlikely to get a government response to the consultation until probably at the earliest, spring 2019. So that's 2 years added on to the process. And as Colin alluded to, I've got this slide which shows over the last 20 years 12 green papers, white papers and consultations on this, 4 independent commissions. And we've had, in 20 years, we have had 12 ministers for care services. And I do think we need to spend much more time getting a deeper understanding of why, when other countries have made major decisions about funding of important long-term care, we have continued to struggle. And I think what's worrying at the moment is and a big challenge for all of us, I think, is how do we sustain momentum behind this, given that elongated timescale, given Brexit, which seems to be sucking all of the policy and political oxygen out of the atmosphere. And also, of course, there are so many now competing domestic policy demands on the public purse, ranging from housing to tuition fees to universal credit, whatever. So this is a really kind of tough environment in which to be grappling with social care reform. So where does that leave us? So here's kind of 4 points for you to think about. I think realistically, for the next couple of years, essentially, you are on your own in local government. There is no cavalry coming over the hill, and the only circumstance I could see that changing if there was some sort of calamitous or catastrophic collapse in the provider market or some other scandal or tragedy. But I think in the meantime, local government and providers are on their own. And maybe maybe localism's hour has come. Because I think many of us have believed for some time that actually, whatever the solutions to social care, they're all local ones, actually. And maybe the role for government is not to do daft things that make it worse, is to sweep away some of the obstacles that get in the way of sensible reform of services and basically allow you to get on with it and provide some stability and certainty. So I think this is the time for local initiative and local examples. Nobody is going to come and bail you out. The second takeaway point, I think, is that in the same time, the NHS is grappling with similar enormous challenges in relation to funding, service design, workforce, and so on, as Michael has alluded to. And it is absolutely essential that county councils are on board and are fully engaged with not just the STP process, but the evolution of accountable care systems, which we ought to welcome, because this is the NHS trying to move towards a place-based approach. And despite all of the flaws and faults of the process, it's the only show in town. And local government has so much to contribute to that, particularly counties, because you are working in some of the most complex health economies in the country, both in terms of the organisational structures, complexity, and the number of bodies. And also, I think some of the toughest performance and financial challenges in the NHS can be found in health economies in county areas. The third takeaway point, I think, is this point about the public's poor understanding. And I think local government could do a lot actually in raising local awareness, not just about current care liabilities, but also the great good that social care does in our society. And I think there is potential. I think most sort of decent people recognise that we ought to spend more on good care that any of us could need at any point in our lives. And this really shouldn't be a matter for either political conflict or public discord. And the vast majority, I think, people would support action. And maybe local government ought to do more in terms of supporting local understanding of some of those issues. The final takeaway point is a bit of a challenge, really, because the flip side of localism is variation. And one of the things I know that the Green Paper team have got firmly in their sights is the very big variations between local authorities in terms of what you spend, what services you provide, what outcomes you achieve. Some of those variations are, without doubt, explainable in terms of local needs and circumstances. Some are not. And it does remain the case that most councils are still commissioning the same sort of traditional services that they were 20, 30 years ago. So I think there's much more to be done within local government about getting on the front foot in terms of understanding some of these differences and justifying them. So I hope I haven't depressed you too much. There isn't a great deal of hope out there at the moment, but what hope there is local. And if there is a big idea in social care, The big idea is that there is no big idea, but there are lots of small ones that work really well, and it's how we apply them consistently at scale throughout the country so that people get consistent service. Thank you very much for listening.
Right, well, thanks very much for that. So we've got Michael's 5 predictions, and we've got Richard's 6 tests, and I very much took away you're on your own, so get on with it. So really keen to open this up and to have a conversation. The most important thing is when you get the mic, remember that we will hear your question, but the people behind you won't. So wait to the mic, say who you are, and the first question's over there. There we go.
Yes, thank you, everybody. It's Heather Smith, leader of Northamptonshire County Council. One of the things we did just over 12 months ago, we used some public health money to put wellbeing advisors into doctors' surgeries. It was really well received, and the objective of that is to try and make sure that individuals take some responsibility for their own well-being, and this is obviously in the interest, the longer-term interests of the NHS, that if you can keep them well for longer, then they're not going to be so costly on the NHS as they get older. We paid for that for a year, but we're in a situation now where anything that's non-statutory, we can't afford to do anymore. So we approached the GP surgeries, and as everybody here knows, they're all private individual businesses. And, you know, we asked them, look, it's been shown this is really working, it's been well received, you've been very welcoming of it, you can see the benefits of it. You know, to keep this going, we need money from you, and it's just not forthcoming. So it means that we're going to have to stop something that we know in the longer term is going to save money throughout the system. I don't know, I'm looking at you from the NHS because obviously it's complicated, it's a private business, should the CCG fund this sort of thing? But it really needs something from the top in the NHS to say, if in the longer term we're going to save money, we have to tackle some of these problems at the root causes. Thank you.
Okay, so as Heather pointed at you, Michael, you can start.
Yeah. Well, thank you, and I think that, I mean, I agree with your premise that what we've got to do is begin to free up some of the resources that are being tied up in acute care in order to get upstream on demand. So that's absolutely the direction of travel that we're trying to push things. I know it's much more complicated in practice. One of the things that we're hoping makes it easier, and you do see it in, for instance, our Vanguard systems and in some of our best accountable care systems, which Richard mentioned, is because we're putting all of our, we're creating a place-based budget. We are inviting people to look across that and ask different allocative questions. And of course, money's tied up, and it's not easy to just kind of move it from one place to another, but it does create freedoms they didn't have before. And so some places where the CCGs are working together with other stakeholders are making different allocative choices, are freeing up money to fund just these sort of things. So I'm thinking of one in Somerset, South Somerset, for instance, but there are many other examples. The other thing I'd say is, the other direction of travel we're trying to, and this is complicated by your point that GPs are independent businesswomen and men, we're trying to get them to come together as well into some sort of scale for resilience reasons, to try to share workforce, share assets, but also because we think that scale is important to try to do this sort of proactive stuff. And it's actually very hard for single people, single businessman or a woman to fund that sort of thing. But in a federation or a cluster, it becomes a bit easier. So we're trying to push them in that direction as well. It may be that some GPs can then get into that sort of business in the way that Modality in Birmingham, for instance, is.
Okay, Richard, do you want
I think your experience in Northamptonshire illustrates exactly why we should support in local government the move towards accountable care systems. The idea that you have one budget for one place and you have the key players around one table sorting out how to get the best value from the public pound is where we should be aiming for, instead of this very fragmented set of arrangements we've got now where the money's cast to the four winds and there's just too many people involved in decisions.
I suppose the challenge there is around the budgetary pressure. All the time it's the budgetary pressure. And even if you have a accountable care system, where does that leave those individual organisations in terms of the cuts they've got to make, and certainly in local government, the constant amount of money coming out of the system?
There is, but I think if you were designing a funding system and a decision-making model that maximises the outcomes you get, would we design what we've got at the moment? There's terrific waste and cost involved in our current very, very transactional approaches. We waste a lot of money, actually, the way we do things at the moment.
So it's that point you were making about you're going to have a long-term staged approach to this. Absolutely. And a route map as to where you're going to take this thing to actually address some of these really difficult issues around budgets. Okay, great. Okay. Graham.
Yesterday in the workshop we said that the NHS was not fit for purpose. In one of the workshops that some of us attended. And Richard, you said we're on our own. I was particularly fascinated, Michael, by points 4 and 5, which you said, systems will integrate services both within NHS and social care. And fifthly, you commented about the public's health or population's health. I think I'll put it back to you both. If we are on our own, and if we are saying that the NHS does need some fundamental changes, we've got to integrate our services. What specifically would you say that we should be doing now to really address the population's health? Because with public health coming into the local authority, that's something which is fundamental to what local authorities are all about, county councils especially, we've got that money. What specifically do you think we should be doing now to fix this and to move the agenda on?
Okay, who wants to go first? Richard.
Yeah, so, I mean, at the risk of stating the bleeding obvious, and I do hope this doesn't come across as patronising, I mean, I still come across parts of the country where local health and social care leaders are not spending anywhere near enough time with each other outside of formal meetings to work out what it is they're actually trying to do and what the opportunities there are for collaboration and sharing resources. So I think sort of getting some sense of the term I used earlier, the public pound in your system. Some places are doing great things, and I'm not going to single anybody out, but there is still a great patchiness on that. And the places that are doing best seem to me to be the places who are investing in local relationships. Because there is going to be tension and disagreement between the NHS and local government locally. We are dealing with almost 70 years of accumulated difference between the NHS and local government across governance, accountability, funding, performance management, regulation, and the spat this year about delayed transfers and better care fund reflect those deep differences in cultures and ways of working. But the only way around that is to invest time locally in developing those relationships, because those differences are not going to disappear soon. And I think the big test always, I think, for partnerships between NHS and local government is not how much you agree upon, because the agreeing on things is easy. It's how well you manage the conflict and the disagreement.
Okay. Michael.
So I guess I'll go for two things on this. One would be to focus really hard on the provider side of integration. So I think the kind of joint budgets, joint commissioning has its place, but I think the really hard work is to try to find some ways of caring for people that genuinely pull services together in a new way. So for instance, in Rushcliffe, there's been redesign of care there where working with care homes and GPs, they're taking nearly a third of admissions out of hospitals and that's the hard yards of kind of at the team level, integrating teams, doing that care redesign. So I don't think there's any kind of alternative for that really hard work. And the other thing I think, which is a little bit more wonky, is I do think there is, and I think you mentioned it in your paper as well, Colin, is the payment systems in the NHS are well past their due. We want to move away from PBR, which is a kind of way of rewarding just activity in hospitals. Some of our best systems, like Dorset, for instance, are operating a flat cash sort of risk-sharing agreement with their hospitals, and that's led them to invest in primary care. That's led them to do different things in the community, and they are actually managing flat activity now. I mean, so there is something about kind of making sure the incentives are aligned, that we're not just trying to fill up hospitals, not just trying to run, that is kind of the old game, and it's time we move beyond it.
Okay, excellent. Okay, so.
Yeah, thank you. I'm from Cornwall. The council of which I'm a member of
has committed itself to paying all the home social care contractors, their workers, the Living Wage Foundation Living Wage, which is a step in Cornwall, and other aspects of the Unison Trade Union Ethical Social Care Charter, to do with training, paid travel time, which is an issue in a place as geographically dispersed as Cornwall. So that's starting from next April. We think that's a key part of making social care work. I mean, what's your opinion? Do you think this is the right direction for councils to go? Do care workers need a pay rise, need better training? The second question I wanted to ask, I was at the Adult Social Care NHS seminar yesterday. I was quite taken aback by the level of hostility expressed by some of the participants towards the NHS as an institution. There seemed like a gut hostility coming from some people who are local government leaders. Now, the accusation seems to be that the NHS has been given rivers of gold, which it has frittered away in recent years. So that's my second question. What do you think about this accusation that the NHS is adequately funded, it's just wasted it all?
So we've got two questions there, one around what we're paying care workers and then the second one. So Richard, do you want to go first?
Shall I deal with that point about the NHS has wasted a lot of money? I think there was an argument that way back in the last decade and the Blair-Brown government, massive amounts of money were put into the NHS, not always accompanied by reform, and a lot of it was put into doing more of the same. But I think if you take a long view, since its creation in 1948 until about the last 5 years, the NHS had about 4% real terms increase a year, which is more or less what's needed to stand still. That has now dropped substantially. So I don't think the NHS is awash with cash anymore, actually. It's certainly true that local government has had much more severe reductions. But now the NHS is struggling really with a kind of a flat funding settlement. So I don't think the NHS streets are paved with gold, actually. And I see absolutely no value in NHS and local government trying to beat each other around the head about who's in a worse financial position. We are where we are, and the great unifying value I think we share, whatever organisations we work for, is that we want our local NHS and our local hospitals to work for us. We want them to be there for us, our families, the populations that we serve at our moment of need. So it's back to this point about how do we best make the resources we have together work to avoid that.
I agree with quite a lot. I think it can be simultaneously true that we are wasteful in the NHS and need to do more about that, and that we do not have enough funding to keep up with demand. So I think it's just, some people paint that as an alternative. I think both are true, in fact. So it's nothing like, the amount of waste is nothing like the quantum that we would need, as Richard points out. But it is still significant, and it means something to taxpayers. So I think we feel that we've got to keep up the pressure on efficiency and waste, as well as making the argument that demand is outstripping the sort of funding that we get. Just I would add that the hostility point, I picked that up a lot too, and it's weird how we kind of divide off into tribes like this, isn't it? And I know it's about the sort of detox issues and the high politics that's gone on and so forth, but it really is massively counterproductive. And I know we've had our part in it as well, but the very best places, the Dorsets, the other parts of the country that are making headway are getting beyond that, or kind of being adults, or realize that being paid kind of a lot of public money to lead institutions mean getting beyond those sort of things.
Yeah. So we'll just come back to that first part of that, and that was about the care workers. Richard.
Yeah, can I just add on to my earlier reply? I think one criticism of the NHS by local government, which I think is valid, is that the NHS has not faced up to some of the tough choices that local government has had to about reconciling need with resources. But in fairness to local NHS managers, that is often because they have not been allowed by their national political masters and sometimes their local elected MPs to face up to some of those hard choices. So I think that is a fair criticism. On the living wage issue, I mean, I strongly commend what Cornwall is doing. Definitely a step in the right direction, but so much more to do, because it's not just about pay, it's about levels of training and some deeper values about how much as a society do we value this essential care work. So yes, I think that's great what you're doing, and I commend it to others. You're doing something. That's the point. You're doing something.
I think when the national living wage kicked in and we all started to go, hang on a minute, have you thought about how much that's going to cost our sector in terms of additional costs for our care workers? And we went back to government and, if you will, they came up with the sticky plaster of the National Adult Social Care Precept. I think a lot of us were very nervous around that. Certainly my council, we were in the midst of 7 years of zero council tax rises, and we were really interested in how that might land. And funny enough, I think it landed very well. You clearly explained why you were applying the National Adult Social Care Precept. It was clearly about paying your workers more money, particularly in the care sector. And actually, I think it landed fine. And I think it sort of semi-informed some of the more accepting of actually applying some increases in the council tax as well. I mean, most of our care providers, and I'm sure it's exactly the same across the sector, they dread this time of year because the Lidls, the Audis, the Tescos, they all start paying a bit more because they want their shelves stacked. And people drift out of the trade. And, you know, when you think what those people are actually doing on a day-to-day basis in care services, and they can earn more money stacking shelves, then we've got something wrong. Now, how we pay for it, that's another challenge. And I think there's also something about career progression. If you look at care workers, there's very little career progression within their trade. So you talk to young people about what trade or career you might go into, care is not very attractive because there is just not the qualifications and what that gets you to the manager status and all those other things. And so I think there's some real issues for us about workforce management and how we shape the market in that agenda. Okay, next question is Izzy. No, you're about 3 in.
Hello. I just wanted to go back to your timescale that you talked about, the green paper and the likelihood of it becoming landing in spring 2019, and just thinking about that and the BCF money and the running out of it at 2020, we're going to be really up against the wire on contracts, on workforce, on our commitment in the longer term. So when you also say we're on our own, actually we're not on our own, are we? We can never be on our own because integration is really the only game in town, but it is dependent on constancy, and constancy is the one thing we haven't got at the moment. So, and can I just throw one more question in? So where's the status of the STP in this? In the future.
So that's 2 questions there. Michael, do you want to?
Yeah, sure. So, well, just on the, I think Richard's right about the localism point. I know it's only half an answer, but it is right that I think the best areas will be striking deals and compacts themselves and not waiting around for for national government to sort this stuff out. I mean, it looks, you know, for all the reasons that Rich went through, incredibly unlikely we're going to get that sort of national leadership on social care. So I think it is up to local leaders to make the most of their place-based pounds. And I think that can be done and is being pushed on in some parts of the country. I think that for us, STPs, forget the acronyms, ACS, STP, you know, the NHS is brilliant at making acronyms. It's a sort of #1 product of the NHS sometimes, I think. What it is about is systems for me. So how do we actually get places interacting, the organizations acting together, sharing assets, sharing workforce, helping to solve some of the problems together, and making their collective pound go further. So an STP, if it doesn't accomplish any of those things, is not worth it for us. It's just a means to an end, and the end is trying to get these services acting in the better interests of their residents and their patients. So, you know, let's forge our own way, not wait around for the government to do it.
So just to clarify the timescale, so the wording of the government statement last week was that the Green Paper is published in summer 2018. My prediction, I do hope I'm wrong, is it will be the very last day that Parliament sits before the summer recess. The consultation will then happen over the summer, and that therefore the earliest we can expect a government response to the consultation responses is spring 2019. So that's kind of my take. So, you know, that's a lot of road to be covered. When I said you're on your own, I mean, I did mean local systems, is it not just local government, but local health and social care bodies and providers, actually. We mustn't overlook the actual folks that are delivering the care.
Yeah. Okay. Right. I'm mindful we're in the last 10 minutes. I've got 4 more speakers, so we'll try and get everybody in. So try and keep it nice and tight, and maybe one question, not 2. But so we'll try and do it before that dreaded box goes red. Keith.
Thank you. Keith Glazier, leader of East Sussex County Council. I'm thankfully just finished the 3rd year of our integrated care work in East Sussex with both the 2 CCGs, the Acute and Mental Health Trust. 2 quick questions, sorry Colin. The first is the relevance of the geography around STPs, because clearly we've got 3 counties and a unitary authority forming our STP, and it's a bit perverse. But we are working at a locality level, and hopefully that's the answer that we get. The second one is if you like, the difference in drawing between NHS improvement with the Acute and NHS England with the CCGs, where the Acute are being told to maximise all of the income you can, at the same time as the CCGs are being told to spread all your money into community care and do it that way. So a quick word on why we've got 2 inspectorate peers not to be working together.
Michael.
One for you, Michael.
Yeah. Just on the boundaries, I think it's we're open to changing boundaries if that's what makes sense. I think that what we'd say is no boundary is the right one, and there's always sort of subsidiarity between them. So we are actually looking to steer from local leadership to tell us what, particularly in that bit of the southeast, the right pattern looks like, because you can't really. I totally get the 2 regulators speaking out of 2 sides of their faces is a problem. We are merging functionally our kind of leadership down in the southeast and the southwest, actually. So we've got a single regional director that acts on behalf of our 2 organizations. I don't think that's permeated all the way through our organizations yet. It'll take time, but we've got from our perspective, the passing costs from one place to another in the health service is not going to get us through this at all. We've got to instead step back and say, here is your share of the NHS and perhaps social care budget, how best to spend that together. So that is very strongly our message at the top of both of our organizations. We've got to get through the permafrost a little bit too.
Okay. You want to? No. Okay, great. Thanks very much for that. Right, sir, you're next. Yes.
Keith Manns, Deputy Leader of Hampshire County Council. Mine's really just a couple of pleas. Can we have no more initiatives, please? Because I do find with NHS initiatives, before you've learnt the lessons from the previous one, there's a new one. So we never learn the lessons. Secondly, I think it's really important just to look at what works and what doesn't, and to share that experience and to encourage people locally to follow best practice. And finally, I think we've got to find a better way of actually engaging with the NHS. Of all the organisations I've had involvement with over many years, it's always been the hardest to get into. It's like walking around in treacle. Loads of people agree with you, but you can never find anyone who can make a decision so you can get on and do something.
Excellent. Right, Richard.
I totally agree with that. And I mean, a couple of points I tried to make was the need for a long-term approach. And we've run out of road with short-term initiatives, haven't we? And one of the big learning points from 20 failed years of grappling with social care reform is that these one-off short-term initiatives just do not work. We've got to have a long-term approach. And actually, I mean, that applies to a lot of big public policy challenges, doesn't it? Like climate change and sustainability and infrastructure and so on. You've got to have a long-term approach. And there's a real problem, I think, with our current political cycle actually encourages short-termism rather than the long view. And another reason why we need a cross-party approach to some of these things.
Well, that's your point about the 6 tests, that if you're going to take a very long-term view of this, you're going to go through X number of political cycles. So it has to be cross-party so it doesn't become the dementia tax, the death tax. That's the key. Michael?
I agree and hear you. We're trying to learn from what works, and that's these Vanguard systems moving to accountable care is meant to be, we've now had 50 systems, we've worked out which ones are producing some of the goods, how can we spread them more widely? So we are trying to be more systematic about working from the evidence and where we can see that these models of care are taking the pressure off of hospitals in particular. If you need help on engaging with the NHS, I mean, very happy to talk to you separately, or Neil McKay and Richard Samuel and others down there are looking for answers, need local government leadership, so very happy to help find the right person if you want.
Okay, Paul.
Paul Carter, leader of Kent County Council. When Simon Stevens launched the concept of STPs, I think it was in his document, the 5-year forward view, which probably should have been the 10-year forward view. There was written into it the promise of substantial transformation fund to lead the transformation. As we all know, that's been subsumed by the overspending of hospital trusts up and down the country, and there's very little left in the kitty for that transformation fund. That's linked to the point that Rob Whiteman from CCN makes, that the amount of money as a percentage of the National Health Service budget going into primary care, community health, has diminished significantly as the proportion of the totality of the National Health Service budget. I think most sane people in STP land have worked out that the essentially needed increased investment in local care leads to a massive saving in hospital budgets, eventually through hospital avoidance services being delivered by primary care, local government in the community health space. Simon Stevens is also very good at putting pressure on Jeremy Hunt and the Treasury to get more money for the National Health Service. Surely that some of that additional money, or a significant proportion of any additional money that comes in, should be ring-fenced to change that diminished amount of money going into local care to a significant increase in local care, because without the application of additionality in that space, I feel that we'll get somewhere very slowly rather than rapid transformation and progression.
Okay. Michael.
Paul, and thank you very much for you being one of the leaders in East Kent that I was speaking about that really make a difference, and so thank you very much for that. But I agree that I'm not sure it'll save us money, by the way, but I do think that it can moderate demand, which means we won't be spending so much in the future, which is a slightly different thing. And I do think that we've got to invest more in community and primary care and local care, as you put it. Whether we can do a ring fence is a trickier one, because hospitals, I mean, this gets to what Richard was saying about the political constraints that we have in the NHS. If people turn up at the hospital, we don't have the option to shut up shop, and therefore hospitals can end up having costs in excess of what we pay them. So I think it's going to have to be a much more nuanced stage thing, led locally, where there's a kind of building up of services that take the pressure off of hospitals, and a changing of the financial incentives for hospitals to reinforce those things. But it's not going to, I think a kind of clear ring fence like that could get us into trouble quite quickly.
Okay, so we're drawing to a close. It's gone red. I've got people at the back. People are pacing, ready for the next session. But I am going to take this lady's questions because she's been waiting very patiently. So it's just this lady. Well, there. There we go.
Hello, I'm Kay Cutts. I'm leader of Nottinghamshire County Council. I'm not due-eyed about the NHS. I think it's wasteful, bureaucratic, and you have too many layers of people telling us all what to do. I think your estate is not properly managed. In Nottinghamshire, we have 2 healthcare trusts, one of which has an enormous PFI debt. It is constantly trying to fight to get enough money in to pay its debt, let alone see its consultants properly reimbursed and give the services to the people. We've also been struggling with a rather ridiculous proposition of having, until last week when I put my foot down, of 3 PCT areas at the bottom end and the top end going to South Yorkshire, Bassetlaw that is. Now, for goodness sake, let's get one footprint for the county, one footprint for the NHS, and then we could probably work together better. I should further add, it's about time we're all fairer funded as well. The East Midlands is the 3rd lowest funded per head of population. There is no excuse for that whatsoever. And furthermore, you've closed down the children's heart surgery in Glenfield, so everyone from the East Midlands has to go to the West Midlands for their children's heart surgery. And that is not an easy journey, because the train journey takes an hour and a half. So, no, I'm not dewy-eyed about it, and let's get pulling together.
So the message from Michael there to take back is you must do better, Michael.
We look forward to your local leadership on this one too, instead of pointing fingers too much. I think it is important to get around the table and do some of this with us.
So thank you all very, very much for that. We've got people at the back. So we're going to capture all of that. We're going to take that away. We're going to add it to the paper. I will then send this paper to you again. Please do pass it around your systems. Please do feedback so that we feed in a sustainable approach to social care. Thank you all very much indeed. Thank our speakers. Thank you.